Also, there is one study that has implicated gender differences between males and females in earlier onset of the disease, but that's just one study so far. All right, now let's look at the organs that are involved, mainly the spinal cord as well as the brain. Well, I say mainly, but on my first slide, I'm already showing you that the repeat size differs strongly between different tissues. So that is something that has to do with expansion that happens inside the body throughout the life, and it can continue throughout the whole lifestyle. So this causes major problems in testing of the disease, because you can't conclude from blood what actual disease length you're going to have in the brain, and the brain you cannot sample at the time you see the patients. So here's an example where you have a very short repeat in blood compared to bigger repeats in the cerebellum and the frontal cortex. Then even inside the central nervous system, the repeat size is not stable. So here you can see that in the frontal cortex of the same patient, you can get a much higher repeat size compared to spinal cord or cerebellum. And it seems that in the cerebellum, the repeat size is less variable compared to other regions of the brain, with about 1,600 repeats on average, and versus 5,250 repeats in the frontal cortex for these patients that were participating in that study. And similar observations were found in mouse models of other repeat expansions, so that's not something that has been seen before. For example, in this study here, the cerebellum had less repeat expansions compared to other regions of the brain. So it seems to be a bit more stable compared to the frontal cortex. And that might have to do with, as one argument is that this has to do with DNA damage repair, which every cell in the body has to do. About 100,000 lesions per day are occurring in a cell, and has to be corrected. So there are three major pathways that were shown to participate in repeat instability. One is mismatch repair, the second one is single strand break repair, and the third one is nucleotide excision repair. And all three can occur if you have C9orf72 repeat expansion. And there's a fourth one that was just recently suggested that could be really important for C9orf72 expansion repeats, which are the G quadruplexes that can be formed by these G-rich expansions, and they are very stable and very hard to go through for the polymerase, and they induce off and down strand breaks. And it has been shown that you need special helicases to go through these repeats and to try to repair that. And depending on how the cell tries to do that, you can even get expansions of the repeat. And so these G quadruplexes have been recently described in C9orf72 ALS cases. So the repeat expansions per se have a very high mutation rate. The mutation depends on different DNA repair pathways, and it often leads to tissue-specific disease phenotypes. Different tissues preferably use different repair pathways, and the sensitivity to different types of damage depend on the mitotic state and also on the metabolic rate and age of the patient. Repeat instability could depend on the frequency of repair initiation, variation in repair protein expression, replication rate, transcription, protein structure. So all these things can affect how this repeat is going to be treated in the different subtypes of the tissue. And the recently described DNA structure, the G quadruplexes, is also one part of this. So for the repeat length and the disease association, there has been no phenotypic aspect that significantly correlates with the length of the expansion. So having a longer expansion doesn't necessarily mean that you're more sick compared to somebody who has a shorter expansion. However, for frontotemporal dementia, it has been shown that the repeat size correlates with the age of onset, although it's not a very clear correlation. And it also has been shown that if you have require the analysis of a large number of patients. That's why it's so difficult to actually determine whether there is correlation or not. And just one example was another repeat disease, which is myotonic dystrophy, where you needed 100 plus patients to actually see the very clear correlation because of other disease modifiers that can kind of bring some noise in the analysis. So then the pathology that can be observed in CNNOR cases. So one thing that is very common are TDP-43 inclusions that we can see pretty much throughout the whole brain and spinal cord, depending on what type of disease the patient is suffering from. They can be vestibular aggregations or cytoplasmic aggregations close to the nucleus. And the other thing that is very typical for CNNOR cases is star-like, P62 positive and TDP-43 negative inclusions that usually contain polypeptides or repeated peptide proteins. These are very unique for CNNOR cases. You don't find them in other ALS or FTD cases. So the TDP-43 inclusions have been correlated with clinical phenotype and with the pattern of the neurodegeneration. CNNOR FTD patients that don't show signs of motor degeneration have significantly less degeneration in the lower motor neurons that have TDP-43 inclusions. Whereas CNNOR FTD patients with predominant degeneration of the lower spinal cord motor neurons show the TDP-43 inclusion predominantly there. So this correlates relatively well with the disease and the disease pattern that the patient has observed. Another thing that can be found very frequently and has been published by many different groups in the repeat expansion research is RNA foci. So you can find RNA foci accumulating in the nucleus in both FTD and ALS cases throughout the whole spinal cord and brain. And these are, as I say, common hallmarks of repeat expansion disorders, and I will talk about those a bit more later. So then let's go to the cell types and to what's happening inside the cell if you're having such a repeat. So the toxicity that we can see, or what we're thinking is happening in neurodegeneration with this repeat expansion, has mainly three different theories. One is the reduced CNNOR72 protein and function. So it can, due to loss of function, it cannot fulfill what it's supposed to do, and therefore the cell is going to die. The second one is this RNA toxicity that is correlated with the foci that I just showed you. And the third one is the translation of toxic TLP proteins. So for the theory of the first point that I showed you, which will be haploid insufficiency, meaning there is not enough protein. There have been three different RNA variants described for the gene, and they give rise to two potential protein isoforms, because the ATG is an exon 2. And the reduction of abundance of all three different isoforms has been reported in different tissues of ALS patients and FTD patients. There is evidence that the variant 1 is stronger reduced compared to the other variants because the repeat is actually not in the RNA itself but in the promoter region. And model organisms, for example C. elegans and zebrafish, show that CNNOR loss is actually per se pathogenic for motor neurons and can cause motor deficits. Then the CNNOR protein has a strong homology with like proteins, or is predicted to have a strong homology with these proteins. And the protein family itself is involved in membrane trafficking. And members of this protein family have been linked to other neurodegenerative diseases per se, so that's an interesting link. In addition, yeast homologs of the CNNOR protein have been linked to sorting of endosomes and lysosomes to the cell surface. And so that obviously caused the question whether CNNOR72 pathology is related to endolysosomal pathways. And there is one disease-modifying gene that is known in FTD, which is called CMHND, and it's known to be involved in lysosome function and transport of proteins to the dendrites. P62 positive inclusions would also point towards dysfunctional lysosome degradation. So that would make quite some sense for so far. And there is another mutation in a gene that is involved in lysosomal degradation of proteins, which is called CMHND, and it has been shown to cause frontotemporal dementia in a damaged family. So there is quite some hints that the lysosomal trafficking could be involved. So after having said that, there is no final proof that this is really the case. And the second theory is the RNA toxicity. And as I told you, these RNA foci that are mainly nuclear, but not only, I will show you some pictures after, they can be made by two of the three variants where the RNA is actually individual. And this has been shown to correlate pretty well with neurodegeneration of FTD patients. So here you have the percent of neurons that have this foci in C9orf cases, and you see they don't find these foci in other FTD cases, so it's really specific for C9orf disease. They find it in the frontal cortex, hippocampus, and cerebellum, mainly all regions that are affected by FTD. And here you see they can find it in astrocytes, microglia, oligodendrocytes, which are major players in ALS disease. And as I mentioned, a few of these foci have been found in the cytoplasm. However, I don't know how good or how stable this data is. I mean, that certainly needs to be confirmed. So the repeat foci are frequently found in affected brain regions in FTD. The burden correlates with clinical disease phenotype. That is also a good point if you want to link it to disease as a cause. And the overexpression of the repeat itself causes neurodegeneration in several animal models, including zebrafish, Drosophila, and others. And here you see a fly that has been subjected to just repeats itself without the environment of the C9orf chromosome. And you can see that if you have 36 repeats overexpressed, the fly still looks pretty good. However, the eye starts to become quite sick if you express more than 100 of these repeats. So this is definitely causing neurodegeneration in the fly. So this is an example from zebrafish, where they did a tunnel staining to see apoptosis in the zebrafish itself, and you can see if they overexpress 38 or 72 repeats, they can actually see increased apoptosis in the zebrafish, which is quantified over here. When you have only 8 of the repeats overexpressed, you don't see anything. And the proposed disease mechanism for RNA toxicity is the sequestration of RNA binding proteins. For example, they are involved in mRNA splicing, RNA trafficking. HNRPH is one of the proteins that is frequently found. So another point that would speak for this type of disease-causing mechanism is the DNA hypermethylation reduces the repeat RNA expression, and it is a disease modifier of FTD. So if you have hypermethylated C9orf72 repeats, you actually will have a milder disease phenotype. This has been shown for FTD, but not for ALS, again. Furthermore, repeat RNA has been shown to be toxic in other expansion disorders like myotonic dystrophies, where the repeat is in the 3' UTR and it's bound by muscle blind-like proteins, and that's actually causing the phenotype in that disease. So the protein is not able to perform its proper function because it's bound to the repeat. And so the third theory is that the dipeptide repeat protein translation itself causes disease. And the name they gave this process is RUN, repeat associated non-APG translation. And it sometimes makes you want to run away because, especially in the case of C9orf72, you have one DNA, 2 transcripts or 3 transcripts. You have those 3 RNA transcripts, 2 protein transcripts, 7 reading frames, which gives you a total of 9 possible toxic entities. So that is a lot of different peptides that can be produced. So the way it works is that the repeat itself can be transcribed in both directions via independent mechanisms that are dependent on the secondary structure of the repeat. And that gives rise to these small peptides that are produced in the cytoplasm. And this mechanism was initially discovered in SCA8, which is another repeat expansion disorder, and it has been described in several other repeat expansions. So in C9orf, there have been many studies that showed evidence for these repeats in there. You can find them in postmortem tissues by immunohistochemistry. You can find them by immunofluorescence. And as we already said, they're giving rise to these star-like accumulations. If you overexpress the proline arginine-rich GRP protein itself, it's also giving you toxicity in vitro as well as in vivo. So here they have been transfecting peptides directly into cortical neurons in vitro. And as you can see, hopefully, after 4 days, you see a marked reduction already of cells that are viable. And at 8 days, there's almost no cells left. So there's a pretty strong reduction in survival just by the peptides itself, if you have about 50 peptides. This is true for proline arginine-rich peptides. Others don't seem to have the same effect. And the same again, when you overexpress these proteins in the fly, you can see that you get toxicity with the proline arginine-rich dipeptide repeat proteins. I'm sorry. It's kind of difficult to say. Then, in addition, the same study that I showed you for the RNA toxicity has been using constructs that are either only giving rise to RNA or can be transcribed into dipeptide repeats. And it was shown that the dipeptide repeats can give rise to toxicity at lower concentration than the RNA only. So there seems to be a correlation between the proteins that can be made from this RNA and the RNA toxicity itself. They might be related. So one fact, though, that would speak against the dipeptide repeat protein approach is that it has not always correlated, if you look at the patients, with the phenotype or the degeneration pattern. And definitely more studies will be needed to decipher the correlation between the disease course and the clinical manifestation and these dipeptide repeats. So this is a summary of all the potential toxic mechanisms that can go on if you are having a C9orf72 repeat. So the repeat can be transcribed in both directions, giving rise to sense and antisense RNA that can then interfere with normal cellular functions because it's binding RNA binding proteins and creating those foci that I showed you. In addition, the dipeptide repeats can cause proteasome impairment, aggregations and inclusions, and this can lead to, it this can happen in all three reading frames. And the antisense RNA can also lead to sequestration of RNA proteins, and it can also lead to the RAM translation proteasome toxicity in foci. So this is basically the whole overview that we've gone through so far, and I would like to thank you for your attention, and I'm ready for questions. Well, that's a problem because in the patients, obviously, you can only do these studies in the CNS post-mortem, so you don't know exactly whether this is a cause or a consequence of the disease. However, if you're looking at the in vivo data, at least in the models, it does cause degeneration, but that's overexpression. But if you consider that the C9orf repeats the expansion, you can also say it's an overexpression of this repeat peptide 79 because the repeat is so large. Is that answering your question?
Is there any mouse model with
There are a few mouse models that are currently being developed, also here at Ohio State by Dr. Arthur Burgess. There is some mouse models in Canada that are currently developed, and overexpression of the repeat itself seems to show certain neurological phenotypes.
But what Brown has done is put in a large repeat back. And it's not really published, but there's a reason it's not published. Because they don't show really any one.
I mean, that's a common problem with ALS mouse models.
Right.
So it wouldn't be the first mouse model that doesn't show a marked phenotype.
But it brings up the question of whether the toxicity that you see in lower species is actually accurately reflected the issue. Just like with SOD1, really the phenotypes of the fly are not exactly the same. So you can argue pro or con.
And the problem is that you've got a really hard time to overexpress such a big repeat. I mean, you can overexpress smaller repeats that may or may not lead to disease in human patients, but that doesn't necessarily reflect the major population of CMHND patients that has like hundreds or thousands of these repeats.
But there are some.
Yes.
so you were trying to not
Yes, there are some studies that use antisense oligonucleotides against the repeat structure or against different RNA variants.
you need 25 or
Yes.
because it's pretty huge.
It has been shown in Huntington's that if you overexpress, if you use oligonucleotides, you can actually downregulate the repeat RNA. It has been done in fibroblasts, but I would say it's not yet clear whether this is really leading to amelioration of the phenotype.
Yeah, I mean, the other one is the ISIS gamma technology, which degrades the RNA. So it's actually not in the repeat. So it can degrade the RNA separately. Presumably you get less expression that way. But there's no good assay for whether the toxicity is disappeared.
So is the expression of this gene required for it? We know the instruction.
No, the function is not known. As I say, I mean, it might be implicated in lysosomal and endosomal trafficking, but apart from that, the function is not known. And the problem is that the current antibodies are not very good, not very specific. That's why I didn't necessarily want to put too much up there because it's so far, I would say, speculation. It has, some of the variants have been implicated in the important neuronal survival, obviously. So if you have reduced expression of exon 1 isoform, you get cell death basically, that happens with whatever you overexpress. If you overexpress the repeat RNA, if you downregulate some of the variants that are involved in disease, if you overexpress the repeat peptides, and so basically whatever you do with this repeat, you're causing disease, which might mean that actually the disease phenotype that you're getting is a mix of all mechanisms that you see.
The one thing I would say with the knockout mouse, which is one thing, fine, it has a phenotype, but you take the whole gene out. That's not what happens in the disease. It's a hypermorph. So nobody has really made a hypermorph. So you need to make a hypermorph, i.e. low expression of the gene constantly present. And certainly the heterozygotes don't show any toxicity, which is kind of a concern for that mechanism. Is what I would say.
Has anyone made any IPS from patient fibroblasts to see if the toxicity occurs whether you're a neuron or astrocyte or microglia?
Yes, there are iPS-derived neurons from C972 patients, and they have been showing that they see the foci. They've also used the oligonucleotides on those. But yet again, I mean, the data is not very convincing from my point of view. We have personally made astrocytes, and they show toxicity from the wild type of the neurons as we see in other ALS cases. So there is evidence, but it's not very strong at the moment for all the individual aspects. But I think that's again a common problem with the whole IPS technology, that it's not really validated to what is going on in adult onset neuromuscular disease, because you're making these cells from stem cell-like cells and you differentiate them for a month. So you're not necessarily sure whether they reproduce or they can actually represent the disease phenotype. I think we're having, with the direct conversion methods that are faster, which basically where you can make neurons or astrocytes from fibroblasts in like a very short time, and you're messing around less maybe with methylation status, you might be able to get a stronger phenotype, but this still has to be proven and evaluated by several groups. So we would say yes, we can reproduce the disease phenotype in a tissue culture dish, but it's again just one of the cell types involved. And as you have seen, since repeat also varies between different tissues, there's so many layers to this disease that actually can play a role, at least in disease modification, that it's really hard to know that in tissue culture.
I'll follow it up. Sorry. I was trying to understand also, there's a model, were you proposing that there's a model that the repeat causes impairment of DNA repair? Is that what you were implying?
No, I mean, that was mainly just to talk about, that was probably a bit quick, that why do you see, different, so why is the repeat so unstable, in different parts of the brain or in different regions, you have different repeat sizes. And one theory or one thing that has been seen is that the DNA damage repair in different regions of the brain and also in different organs or in blood, obviously depending on whether you have dividing cells or not, is different. And that could, lead to the changes in the repeat size.
But, I mean, taking that up, I mean, is it equally possible that it's just using meiotic instead of meiotic?
Yeah, could be, yeah. I mean, also, one point is that the repeat also increases during your whole life, which would say the CNS you have some quite a part of the cells that don't divide anymore, but in that case you would have to go and probably look at individual populations of neurons versus astrocytes or neuron progenitors to see, Yeah.
I have two questions, but the first one I would just
fibroblasts or skin samples and converting them into the respective cell types, do you think that you are still actually capturing the similar repeat sizes that are actually present in the patient astrocyte as we are seeing? I mean, it's good that we are seeing the phenotype, but is it still the actual phenotype? And then the second, on the same thing, I would say is when you are talking about direct conversion being faster or much less time period, that also means there are maybe less time for all your DNA damages and repair mechanisms to go through. So are we actually then looking at the exact same phenotype, or the patient astrocytes would be actually more toxic than what you would actually get if you make them from fibroblasts?
Yeah, I mean, that's a very good point. Certainly, I would say the fibroblasts cannot absolutely reproduce the repeat size that we see in the brain as we see for blood. Sometimes they probably will, other times they will not. So I think this would depend on, first of all, the patient you would have, secondly, one thing that has been shown to correlate fairly well, but it's just one study, is the methylation. So the methylation, the hypermethylation actually has been shown to be in the same patient, at least in blood and in the spinal cord tissue or in the CNS tissue, pretty conserved. So at least this is something you could look at probably in the fibroblasts as well. In terms of repeat toxicity, are the astrocytes more toxic? It's hard to say, because once more when you look at the brain, it's end stage. Also, you don't know with all the inflammation that's going on, whether that is also changing your DNA damage repair pathways. We don't see that that is going on. Certainly, I would say that you will have larger repeats than what so far has been.
The second question that I had was, with the first part of the hypothesis that you said that it might be the loss of function. So you meant of the C9 or variants itself. You mentioned that in the zebrafish models also that it has been shown that the loss of the allele itself actually results in the neurodegeneration and all. Have there been any rescue experiments done in those models where if you put back one of the variants, it actually results in the non, or like a rescue of the phenotype, showing that okay, it is the loss of one of the variants that is actually causing it?
This I don't remember, because it was a knockout of the whole gene. I don't remember if they overexpressed the virus anymore.
But I think there's a big problem with those experiments in that it's really in man, it's a heterozygote. You've got a normal allele. So that normal allele is not particularly effective, right? So, yes, you've got reduced expression. That's undeniable. None of these models reproduce reduced expression. And is it below 50%? So, I mean, otherwise it's a problem. Otherwise you should make them. You should be using the heterozygote. But it's difficult to publish a heterozygote with no phenotype. So, consequently, we get different papers that make different claims. So, I think that's a difficult component of it. And you could look at the repeat size in your fibroblasts that you've converted and ask whether one with a great big repeat is any different from one with a small repeat. But again, I point out that the disease doesn't correlate to repeat length and severity. So is that really worth doing?
That's the case for ALS. For FTD, it seems,
yes.
at least in the cerebellum, that the repeat length seems to correlate to a certain extent with disease. That's another thing that is probably a bit frustrating for ALS research. I mean, so far, whatever they found in FTD to be correlating with the disease was not the case in ALS. So there seems to be pretty strong differences there.
How much do we know about the expression of the variants? Like even in what application? Are they because of different cell types? Are there cell type specific isoforms? Are there differences in the abundance of the three?
Yeah, I mean, all three of them have been shown to be reduced so far. They usually have been expressed in the same compartment, but they didn't really go too far into details about see where actually which variant is expressed. I haven't seen any. There are some in situ hybridization showing that the RNA is very abundant in neurons. Based on I think by Kathrin Meyer, which was a beautiful study. So it's very abundant in neurons, the RNA. But the problem with the protein is not small. We don't know because the antibodies are not good enough at this point to distinguish it, to detect like
So how So first of all, the sporadic cases that have C9orf, so there's no expansion. What happens like that? Is it a risk?
yeah, most of them are sharing the risk allele, and there are some that do have the gene. So there seems to be very common.
Okay, and so in African Americans,
Well, I mean, I have not done the studies by myself, but so what they basically did, I mean, there was one big study where they looked at these age differences on that, where they included Asian populations. They're saying they included African populations, but maybe it was more like descendants from the African population. And then just based on the SNPs they looked at, they calculated that the common origin, because they didn't find any evidence for close recent relativity, that they said it must be older than what we thought before. So the relationship between the populations doesn't seem to be close enough that you could say a common ancestor has carried this allele at the time the Vikings were conquering Europe. But you are certainly the bigger expert in
there's something very, very strange there because you've got something that's undergoing a high mutation rate, what you said, but it's occurring on a single haplotype background. So the two somehow don't completely jive with one another. I mean, it strikes me that what that tells me is that the haplotype background or the allele is already expanded and sitting there.
well, or it allows for more expansions,
Or it
which
allows
would,
more expansion.
I mean, this is clear. I mean, this has been shown also in the unaffected population that, you know, carriers of the allele A, maybe I went through that too fast, even though they're healthy, they're tending to have bigger repeats. So there's something on this haplotype of allele A that is actually allowing these repeats to happen more. So they're not disputing that this has a common ancestor, but they're just saying it's probably older because of the distribution worldwide and the lack of
It's a risk haplotype.
yeah, it's definitely yes. But there are patients that have the G haplotype and do have the expansion. So it's not completely exclusive.
Yeah, but that, I mean, that's just a recombination that's happened some of the time, whether it's a inside, let's see how that. Dennis, you want to discuss the genetics more?
Good.
Well, actually, I'm sorry, I should have asked this question before the class days, but I'm still a little bit confused with the risk allele and the expansion. So can you just please explain, like, so the risk allele is different than what you see as a C9orf expansion, and so the risk allele is not the expansion. Those are two
No,
different
yeah, so
things.
the risk allele is just determined by markers that are flanking the repeat expansion, and they've been shown to be common in ALS patients that are having the expansion, plus in healthy patients and healthy individuals that do not have an expansion, but they might have bigger repeats per se. So it segregates with the disease. It seems like there is a certain type of allele that is the culprit of the disease, but it doesn't necessarily cause disease. It just probably allows, or certainly allows,
that is the case where this risk allele actually increases your risk, what research is going on identifying what is it actually that causes these expansions? I mean, you know the expansions are there. It seems like there are multiple mechanisms with which it might be actually happening. But if you are also showing that this particular allele gets segregated, is there any work going on identifying how that allele actually modifies the disease? Or we don't know what it is?
I don't think we know what it is. I mean, I think it's right at C9 or loci, right flank. So, I mean, I think what you say is that the easiest one for that is that it's slightly bigger to start off in terms of its expansions.
Well, actually, there is evidence, I think, for a second repeat expansion on the same locus that is close to the first repeat, but this has to be compared. So there could be an additional, disease modifying expansion that is actually segregated like exactly this one. But at the moment, as we said, we don't really know, what it is that is causing this additional disease.
So to continue on that, what kind of gene are around C9 of? Because this sounds to me like FSHD, kind of where you have a haplotype and an expansion. So what?
Life SHD is contraction, but okay.
That's your type.
This I don't know. I mean, I need to check it right now.
Yeah.
I mean, by analogy with FSHD, if you're going to go absolutely, and I'm going to take a slightly biased opinion because that's my nature. Okay, is that FSHD is a contraction, and the key contraction is the DUX4 gene. So, and in my view, the genes around it are 90% irrelevant. Okay, it's the DUX4 and the hypermethylation of the DUX4 locus and whether it expresses something from that. So if you take that as an analogy, then it's got to be C9 or 72 that's critical.
Yeah, but so then there's a variant around.
Yes, the alters expression of it, yes. Yeah.
I have a question for someone who's watching the class. So when you examine the genomes of ALS patients with genetically increased C9 or 72 repeats, do you also see time-to-time repeat increases at other loci?
So the other loci does I assume whether the dinucleotide repeat proteins are a marker for whether this person, so if this person has FTD, whether you would see more D-peptides in the brain or whether you would see more in the spinal cord. Is that the question?
No, it's to do with CA dinucleotides. So when you look at different variants in the region, you've got this, which is an expansion of, depending how you're going to read it, 4 C's and 2 G's, which is an expansion of that. But polymorphic markers that lie close to that, which would be CA dinucleotides, which are a common polymorphic marker that
Oh, okay.
was
The
used in
microscope.
prehistory. Do they change simultaneously with the changes at this 4 C's to G? Or depending
Well, it's subtracting both first. To my knowledge, they're not changing as far as I've seen, but I'm not the absolute expert in genotyping patients.
I mean, I think there's two problems there. One, if you've got linkage disequilibrium, which is what we're talking about here, then what you predict, though whether it occurs, what you predict is the CA dinucleotide should also be in linkage disequilibrium. However, because they're dinucleotide repeats, they undergo more frequent mutations. So it's actually a very good question. So if you look at SNPs versus
would say this additional repeat expansion that is reported in some cases would be a case of severe repeats. This, I don't think it's a severe repeat.
Yeah, I think it's interesting if you look at SNPs versus CI, they're particularly close, would be an interesting thing to look at. That doesn't answer that question, I know.
So the question is, the answer is basically, to my knowledge, no, nobody has reported this change, but that doesn't mean that it doesn't exist. Especially if